The issue now is, can we transport the Steiner art to me, to Professor Lichtenberger, to Kerry Olson, to the young people in the audience, and can we duplicate that? So my question is, and the organizers asked me to ask a question, is laser surgery standardizable? But I would even go one step further. Is surgery standardizable? Unlike medical oncology, you have 100 milligrams per square meter, and that doesn't change, regardless of who gives the injection. That's standardizable. Radiation oncology, less so, because there is an art involved in designing the portals, and even with IMRT. But it's still standardizable. Can we standardize surgery? And let me ask the panelists. Professor Hiro? I'm going to call upon several individuals from the audience also to make this a much more interactive panel. So if you are called upon, please be responsive, because I want your opinion from your part of the world also.
Okay, my opinion, it's very difficult to standardize surgery in principle. And to standardize laser surgery is much more difficult. You must look at every patient, you must see the localization of the tumor, and then you must decide what you would like to do. And Wolfgang Steiner showed some patients with tumors of the larynx infiltrating the arytenoid cartilage. And a lot of colleagues from the audience would decide in those patients not to perform laser surgery, but to perform laryngectomy, for example. And therefore, it depends on the patient, on the condition of the patient, and it depends on the experience of the surgeon. And therefore, I'm really sure that laser surgery is not to be standardized.
Let me ask the advocates of laser surgery. Petra?
Yes, I would say that's true. For the basic difference between the classical partial laryngeal resections and the laser surgeries, that the laser surgery follows with the resection the tumor. And the classic surgery, the surgeon has to decide whether the tumor fits within his resection lines. And with the classic partial resection, the resection is always the same. And this is necessary to achieve a reproducible functional result. And this is not the case in laser surgery. For example, I can remove half of the arytenoid cartilage, or only a part of the vocal cord. And so the variation of the operation are very, very big, and with this number of variations, it's difficult to standardize this. The only attempt to standardize is in the vocal cord surgery, and in the vocal cord surgery with classifying the extent of resection of the vocal cord. There a certain standardizing may be the case. This may be true, but in the more larger, more extended resections.
So what you are implying is that while the surgical technique may be standardizable, surgical judgment and experience is not standardizable. Yeah. I think we will all agree with that.
Yes, I agree.
Let me expand this to some senior members in the audience. Jan, I would like you on the microphone. Pat Bradley. Pat, is surgery standardizable in the UK? How do you handle that?
Simple answer is no. I think the problem we have in the UK is that ENT surgeons are remaining ENT surgeons and not specialising in oncology. And as a result, each individual is not getting sufficient experience or exposure to a large enough volume to train himself to do laser surgery. And I agree with Petra. I think the glottic area is actually fairly simple and straightforward in order to manage, but I think the supraglottic area is a whole bundle in itself. And I think you've got to start with the easy ones and work your way along. A bit like, as Rene said, we can standardize total laryngectomy, but I do think that once you start to modify the total to a lesser, then you need the exposure, and then you need the judgment, which I do think comes with a lot of time.
Okay. Jan?
In Scandinavia it's divided, but in Norway both the National Hospital in Oslo and we in Bergen are treated small glottic carcinomas by primary laser, endoscopic laser surgery, T1, small T2s, and also recurrences after radiotherapy. And when we are coming to the supraglottic area, many tumors are advanced when they are coming, and then they go for perhaps radiotherapy, chemotherapy, plus laryngectomy if that is necessary. But the number of cases is increasing when it comes to laser surgery. We are embarking on larger tumors and then combined with postoperative radiotherapy. Coming to standardization, I think standardized laser surgery, I don't think in the larynx it is more difficult than standardizing endoscopic sinus surgery.
Okay, let me ask Professor Steiner. Wolfgang, how do you handle the training of your young surgeons? When do you let them start doing a case by themselves, and what do they start with?
Normally, everyone has to assist over years to see the surgery done by the more experienced surgeon in my hospital. At the moment, I have 6 doctors who are doing laser surgery for cancer, 3 younger and 3 elderly ones.
So at what level of training, let's say first year, second year, third year, fourth year?
Normally they start with cancer surgery when they are specialized for ENT. There is not a training for the young residents. It's selected doctors who are interested to learn more in surgery generally, and laser surgery especially, and then we assist them. The experienced doctors are dealing with them and help them.
Should one confine to just that work, or any head and neck surgeon can be trained to be competent in endoscopic laser resections?
The problem is we in Germany, ENT doctors, everyone use microscope and endoscopes, and it's a little bit different to the rest of the world that, as you know from your country, they are general surgeons and then they are head and neck surgeons, and they make fantastic flaps and reconstructive surgery, but they have difficulty to be trained in microscopic surgery.
Okay, I will take questions from the audience as we go along, so please feel free to come to the microscope as we move along. I'm going to ask the panelists, go ahead, Jan.
One comment, I think at least when you have a small volume of cancer cases, it should be perhaps 2 people doing most of the cancer cases when it deals with the larynx. In the oral cavity it's easier. We use quite a lot of laser for that too. But for the larynx, I think it should not be divided at too many hands.
So what both of you are implying is, one, this is something to be done by an experienced laryngologist, where there is experience in judgment and experience in technique. Number 2, the concentration of cases should be limited to a few people in the department rather than everybody doing 2 cases a year. And that implies to some of you who are in private practice setting in the community, doing 10 larynx cancers a year perhaps is not the right thing to do, and it may be the appropriate thing to develop the expertise in some areas of or centers of excellence. Let me ask the advocates of endoscopic laryngeal surgery, and I'll ask, this question is both for Petra and Wolfgang. What are the contraindications for laser resection?
You know, in the first years, when you look at our papers from 1982, 86, I was describing that if cartilage is invaded, contraindication, then if neck is infiltrated, contraindication, and gaining more and more experience, these are no more contraindications. It means in the anterior larynx and laterally, until you can follow the tumor, you remove the cartilage, and if it is, the exposure is not adequate, you can switch to external approach, but always using the same surgical principles with microscope and laser. And so you can, the limits in experienced hands is the function. If I have some patients who have no more arytenoids, they have half of the cricoid removed for several surgery for recurrences. But in the first surgery, I would never remove immediately both arytenoids. So this is a real limit. And in the lateral wall cancer, if you have spread, extensive spread to the carotid artery, this is a contraindication to do it only transorally. You have to combine it from outside, or we would say with this large T4, we would perform simultaneous chemoradiation.
So bilateral arytenoid involvement and deep infiltration of the lateral pharyngeal wall.
Yeah.
Yes, sir?
Yeah.
In addition to these limitations, I would add that there are very rare cases where patients cannot undergo surgery for medical reasons. Yeah? The patient must be fit enough to have general anesthesia. This in 99.9% is the case, and in the cases where when the anesthesiologist didn't want to do anesthesia in the first line, then for recurrence for the total laryngectomy, everyone was able to undergo general anesthesia. So there are no real contraindications for this. And to the limitations, I would say Wolfgang listed all the important points.
Let me extend that question to both Professor Werner and Professor Ero. In your judgment, what are the limitations and contraindications? Where would you say this is not suitable for laser resection?
I think this depends very much, again, on the experience of the surgeon. This is the most important thing, and this is the most important point for this whole discussion, because if you are very experienced, you can treat a lot of cases and a lot of advanced cases with laser. And if you visited some courses and then went back home and start to treat these advanced cases laser surgically, I think this is a very high risk. And this is the most important problem. Of course, you can do all these things if you are very experienced, and if you see only a few cases in a year and some small cases, I think it's not allowed to do these advanced resections in such untrained physicians. This is my opinion.
Professor Ero?
Yeah, I agree to all the others, but I think Wolfgang Steiner has emphasized this. You must be able to go onto the tumor from inside and from outside. You must be able to switch on the resection from outside when you start from inside, because during the operation procedure you see the tumor is infiltrating the lateral wall, you can see the carotid artery, or you can see the tumor is through the cartilage, and then you must be able to go from outside. You must be specialized in the field of ENT oncology, and then it's another smaller part to perform laser surgery. Smaller part, that means you must be experienced in this, but you must be experienced also in classical partial laryngectomies, for example.
Okay. Professor Steiner.
You must be able to handle the complications. This is one important point. If you have a very severe bleeding, so you cannot do it in the office, a T3 supraglottic tumor when you are not really trained. But the problem is, when I go around the world, people in the elderly professors in the first line stand up and say compliments, you are a wonderful surgeon, but in our country, unfortunately, we have no experience, so we continue to radiate. This is not right, because every kind of surgery can be learned. So I always ask these professors, do you do stapedectomy? Oh yes, we do in our country, in every hospital. Oh, but there was House in Los Angeles. He was the best surgeon. Have you sent all the patients to House, or did you surgery? So I think it's important to do step by step, to start with early lesions and do continuous T2. And I tell you, when you start and do again and again supraglottic T2, epiglottic fold, then you are keen to do more and more, and you gain more and more experience. You don't need our experience of 27 years to learn all the mistakes or the errors and advantages. We give you in courses and with our book, we help you to introduce faster in this fascinating surgery.
While you are on the subject of complications, what complications would you anticipate besides bleeding, or have you experienced, and how do you handle them? Perforation of the esophagus, esophageal perforation. Have you?
Esophageal perforation.
Esophagus perforation?
Yes, during endoscopic resections.
Doing endoscopic resection. Oh, if the hypopharyngeal cancer is infiltrating the esophagus mucosa or paraesophageal, I go down and then we give antibiotics, a feeding tube, because we open the mediastinum. You can do it, and I told you yesterday I have removed radiogenic tumors completely, the upper part of the esophagus and completely the hypopharynx in two-stage procedure. And he's now 2.5 years alive and can eat and drink. So you can do many things if you have experience. But I think we have, this is the reason why I like to teach in the future when I'm retired next year. I go into the 5 continents and I sit close to the young surgeon to help them to do surgery.
What in the judgment of the panel is the minimum number of cases one should be doing every year to maintain the expertise? 5, 10, 100?
2 people.
Let's start from Professor Ambrose and we'll go across.
This is a good question. For this question
to maintain the level of expertise and build the
minimum. What should be done in a hospital is now the question in Germany.
For a surgeon.
By the surgeon.
By the surgeon. By one surgeon. Not by the hospital, not the caseload for the hospital, for one surgeon. What should he do?
At least every week, 2 cases.
2 cases per year?
For a week.
Per week. So we're talking about at least 50 cases.
One or 2 cases a week. But you know what we have now discussed in Germany, that some kind of surgery is performed in some hospitals only 10 times a year, and in other hospitals 500 times.
Well, let's reduce your number by 20%. Let's say 40 cases. How many of you in the audience do 40 laser resections per year? Raise your hands.
Yeah, there are. Yeah.
1, 2, 3, 40, 40. Not 14, 40. 40. 3, 4 people. So keep in mind, that this is a surgical technique you want to concentrate, if you are going to concentrate upon that to develop the expertise. There was a question, sir.
I have a question to Dr. Steiner. You mentioned you have 27 years of experience with around 3,000 patients. You also mentioned that we need comparative data, and I don't understand why you haven't done it yet.
Comparative data?
Data on comparing with alternative treatments.
We have published a lot of paper with the results of our institution. And some of these patients were treated in my time in Erlangen. But what I like to tell is that the problem is to compare results is nearly impossible. Only with randomized studies you can compare results. So you have your experience in your institution, and then you look at the radiotherapeutic results in England or in America, and then you look at our material or open surgery. The problem is there are always different approaches, different cases. This is so difficult to compare the results. We can only demonstrate how we do it and how are our results and the recurrence rate in organ preservation, but we need prospective studies in the future.
That's what I mean. Why haven't you done it?
Yeah, and yes, this is she has to do it.
This is a good question.
Yes, this is a good question. Thank you for now I understand.
This is really a good question. May I answer?
Yes, of course.
Yeah, I would say in principle, we worked on laryngeal partial resections, and in principle, we have learned over the years that you can do every partial resection you do from an external approach. You can do it with the same resection from an endoscopic approach, yeah, and for the reason that you can expand the indications for partial resections by means of endoscopic laser surgery. We have completely moved from the classical partial resections to the endoscopic approaches. The oncological results are the same. The indication can be expanded, and the functional results are much better. So for us as a group, it's very difficult, to say to a patient, please choose. You could have an endoscopic approach or a vertical partial resection, or maybe another treatment. So we would not be very much keen to participate in such studies.
The problem is, since some years we are discussing from the oncological study group, Professor Werner and Iro, chairman of the study group, to conduct a prospective study, T1, T2, selected T3, base of tongue, piriform sinus, larynx, to make this prospective study. But we cannot make any prospective randomized study, because I cannot remove a T3 piriform sinus cancer with total laryngectomy when I have an excellent alternative with excellent results. No ethics commission in Germany would allow us to make a randomized study. What you always told me every time we met in meetings, you said you have wonderful results, but you need that 5 to 10 institutions have the same can reproduce the results. And we were waiting a long time until we are happy now, and we know that there are institutions who have the capacity, they are able to do it, because you can make maybe a radiotherapy in every hospital, university hospital, but not in every hospital is an experienced laser surgeon. So now is the time, and she has to organize this study together with this gentleman.
We will probably have that answer at the third conference 2 years from now. But let me ask you this. You yourself pointed out that selection of cases is crucial. You mentioned that in 27 years you have done some 3,000 cases with endoscopic resection. What, in your assessment, would be the number of patients that you did not do endoscopic resection? In other words, what percentage of patients in your practice are suitable for endoscopic resections?
Yeah, in early clotting cancer, 99% are treated primarily by laser. And I have the results here with me. I told you this. T1 vocal cord cancer, 333 cases, excellent control, 96% 5-year Kaplan-Meier control, 1.5% secondary laryngectomy. So these patients are not selected. There were only 2 cases. One has treated cheek and one eye. In a course that was not possible to expose it adequately. All other patients, and supraclotic laryngectomy and hemilaryngectomy, we have performed, now I'm 20 years this year, one open surgery in Göttingen. All other cases were treated primarily by translator. But in hypopharyngeal cancer, about 75% of the cases who come into the hospital are suitable for laser. Other one has T5 and N5, no? And they are no cases for surgery at all.
Although I noticed in the numbers that you showed, with stage 3 and stage 4 disease, majority of them were T2 or T1. The stage was upstaged by virtue of the neck nodes and not by virtue of the primary tumor.
Yeah, but you have seen the T3 and T4. Yeah. I have presented T3 and T4, and you are right. This is why I always say, when we are talking about studies, stage 3 and 4, it's not okay, because you have T2 and 1, and nobody in Germany would treat this by a radio or chemoradio. This is an ideal case for transol or open partial laryngectomy.
Okay, let's move on to a little bit more controversial. Is Professor Budash in the audience still?
No.
Any other radiation oncologist?
He has unfortunately no partner in Berlin who is doing laser surgery in this way.
Okay, great.
In our big city, Berlin. This is
All
a
right,
very
let's
sad
take a
situation.
Few scenarios, and I think we will take, these are hypothetical situations. Early stage glottic supraglottic hypopharynx and advanced stage T3, T4 glottic supraglottic hypopharynx are hypothetical situations that we would address. My question to the panel and to the audience is, you have got a mid-chord T1A glottic carcinoma, mobile chord, mid-chord exophytic lesion. And I want a short answer from the panelists. Treatment option. Mid-chord, T1A, yes.
It's not necessary. You ask me, I will always say laser, okay?
Okay, fair enough. So we will ask only 3 panelists. Professor Hiro.
Okay, let's start with T1A glottic carcinoma. I think if it's possible to expose a tumor, then we will perform it by laser. But in some cases, Steiner mentioned it, it's not possible to expose the tumor, and then it could be necessary to come from outside by external approach. In T1B glottic carcinoma, it's a very difficult field. If you have infiltration of the anterior commissure, that's a very problematic area. And you must be very sure to resect all the tumor. There are a lot of publications in the last 20, 15 years dealing with the involvement of the anterior commissure. And in this area, you must be really sure to resect all the tumor. If you are not really sure to do it, then it's better for the patient and for the surgeon, in my opinion, to perform external partial laryngectomy, because the goal is not to perform laser surgery. The goal is to remove the tumor, preserving the larynx. And if you are not really sure to be able to resect the tumor by laser surgery, by endolaryngeal approach, then in my opinion, it would be better to come from outside. Failure of T1 and T2 glottic carcinoma.
Moment.
No, we're just right now.
He forgot radiotherapy.
T1B.
He forgot radiotherapy as well.
Of course.
No.
Professor Werner? T1B.
T1B, I do agree with Heine Iro. So if there is a deep infiltration of the anterior commissure, we have also the possibility to do an external approach.
Okay, so you would operate on this patient. Yeah. Petra, I presume you laser.
I would do it endoscopically, yes.
Okay. Now, have any of you produced, observed, or reported on the quality of voice?
Voice, the results of voice.
Following T1B resection.
All our patients who have in the larynx laser treatment are seen before and after surgery, and continuously for follow-up in the phonetic department with endoscopy, with stroboscopy, and objective voice analysis. And of course, whenever you have a synechia in the anterior commissure, the voice is not the best. Maybe after radiotherapy the voice will be better, but my comment is always, what is more important? To have a little bit more voice or less, or to have more recurrences, more salvage laryngectomies? And this is true, then when you radiate all these people, you have in the world literature a relatively high rate of recurrences and salvage. What is more important, voice or life? And preserving organ.
In all fairness, we have to get that number from the radiation oncologist. What's the failure rate of T1B vocal cord cancer irradiated?
Well, the best theory is about 5 to 8%.
5 to 7%. Failure rate for endoscopic resection?
Moment, please. This is probably from Gainesville, because every radiotherapist worldwide always is not telling his own results because he has no own results.
But we don't have your results
everyone is considering the Gainesville statistic, which is not honest and is not true, is not correct statistic in Gainesville. Nope. They exclude patients, unbelievable. And I tell you, Mendenhall, you know Mendenhall.
But aren't we doing the same thing?
I was in Gainesville 3 hours, and I tell you the statement of Mendenhall. His statement was, I agree that laser surgery is the best treatment for early clotting cancer and no more radiotherapy. And in England, even Bradley is not so convinced, but we have trained 120 ENT doctors in Göttingen and with David Howard in London. And you will see in 10 years, there is no more radiotherapy for T1 cancer in the United States and in England.
But I think, we have to be fair to the audience.
Money.
We are also comparing the experience of one institution for laser resection. And that's Göttingen. Okay, let me ask other people. Kerry, what do you do at Mayo Clinic? T1B.
For T1Bs, we would initially approach those with a laser resection, and if we had difficulties due to deep infiltration of the anterior commissure, we would convert that to an open procedure.
Okay.
But we would clearly do a surgical approach for the majority of those.
Renee? Amsterdam?
T1B, we would primarily irradiate.
Okay. Ryder? Finland?
Radiate. Yeah, unfortunately.
In Finland, T1B would be radiation.
So, ladies and gentlemen, I think what
I have
we are
trained
talking
12
about
people from Finland.
is...
12 people from Finland.
Oh, I forgot. How can I forget my former rulers? UK, Pat Bradley.
I think that there's a controversy in T1B, certainly in the old literature, that they were not scanned. So you're mixing soft tissue T1B and cartilage involved T1B. And I think until we get that done, we're never going to have an honest answer, because I think they were all irradiated in the past, and those that failed, I would hope, were all the cartilage involved patients, whereas the soft tissue patients can be irradiated and they don't get any recurrences.
Correct. No. Georgie? Hungary?
I think that is a very important question. Everybody mentioned that we are not able to detect whether the tumor reached the cartilage or not. I don't know any possibility, even with MRI.
You see it during surgery. Doing laser surgery, you see exactly the extension of the tumor. And by the way, John Kirchner has shown that T1B never infiltrates cartilage. We are talking about tumor with supraclotic and or subclotic spread, and these tumors have a high risk for spreading out to the next through the cardiac or into the cartilage, but the real T1B never infiltrates the cartilage. And the advantage of laser is you cut through, you take out piece by piece, and you see what happens. If the exposure is good, you remove the tumor. If not, you do it from outside.
So you mean T1B tumor if involved both vocal cord and only the anterior commissure, but not below and above?
There is no cartilage invasion at all.
Okay. I think the issue about T1B vocal cord will remain in doubt as long as we have people who subscribe to one philosophy. Mm-hmm. You need to have clearly a prospective, randomized, well-controlled trial to answer the question. And that's not only for tumor control, but accurate assessment of the extent of disease at outset, cartilage invasion by adequate imaging studies, either CT or MRI, pre-treatment, tumor control, quality of voice analysis, and eventually patient satisfaction. Until such time, I think both treatment methods are acceptable in the hands of the people who have the expertise to deliver the treatment. This is a patient that you are going to see who had, and you might be happy to listen to this, had radiation therapy for T1B carcinoma. This is 3 years following external radiation therapy using wedged portals, parallel opposing portals with wedges, so it was appropriate dose distribution. And the tumor, as you see, now has recurred, involving the anterior 2/3 of the left true vocal cord, anterior commissure, anterior third of the right true vocal cord. Radiation failure. Both cords have mobility, but the mobility is reduced bilaterally. Airway is satisfactory. Choice of treatment. Professor Werner? Patient is 68 years old.
Yeah, no laser surgery, open approach, partial laminectomy, to try to do this. Because I think after these recurrences, after radiation therapy, after involvement of the anterior commissure, I have to expect, and we had such cases, that there is a spread through the anterior part and up to the thyroid. We had one case up to the thyroid. So I would do an open approach.
Open total laryngectomy?
Of course, now we have to analyze all the imaging and so on. So what is the exact extension of the tumor?
Thyroid cartilage is not involved. There is no destruction of thyroid cartilage. Cricoid is free. There is no subglottic disease.
What is the reason for the impaired cord mobility? Is this fibrosis?
Probably fibrosis. Probably fibrosis. They are
Probably
stiff.
fibrosis.
And the areas are still mobile.
Arytenoids are mobile.
That's perfect.
You can, endoscopy is possible.
Yeah.
Okay, Professor Hiro, I'm coming to you. Wait, give me a chance.
If you are sure, using CT scan, that you have no infiltration of the cartilage, then in my opinion, I would prefer laser surgery, because after radiotherapy, you have sometimes a lot of complications opening the larynx while preserving the larynx. And therefore, in this case, in my opinion, the treatment of choice would be the endolaryngeal laser resection.
Okay.
And only if we find during the operation it's not possible to resect it, then you must switch, but the first treatment would be laser surgery.
I shouldn't ask you, right? You said don't ask me. The answer is laser.
No, I think that many don't understand the principle of our concept. The principle is try to do it first endoscopically. If it works, it's okay. If not, you can combine it with open surgery. And if you have problems with vocal cord impaired and fixed and the patient cannot swallow, then you do the total laryngectomy. Most of you would do it immediately, though we give the patient a chance and we follow the tumor. I don't need a CT scan. For what I don't need a CT scan? I see it much better during surgery. How is the extension of the tumor? This is the best staging procedure is laser, because you follow the tumor and you see the spread. And we have, by the way, to the discussion before, we have a lot of false positive and false negative CT and MRI. And this was in the last panel or the panel before. What I said for evaluation, when you say complete remission, this is your opinion. You are never sure that the patient has tumor. I have enough cases treated with complete remission after chemoradiation, with a lot of tumors submucosally, but they were classified, and I have seen complete remission. By the way, so you need imaging techniques only if your decision, partial laryngectomy or total laryngectomy, then you need a lot of sophisticated. But whenever your concept is, I try to perform organ preservation. So please follow the tumor, take it out. What is the risk?
Okay, short answer from Professor Ambrosch.
The last question.
Endoscopic resection, open total laryngectomy, open partial laryngectomy.
Also, I would do an endoscopic resection. I think if there is no cartilage infiltration, no sign for this, no infiltration of the neck, and the impaired mobility is due to fibrosis, then it's justified.
Let me give you three options here, and I want to see what the audience would do. Is enough senior people in the audience. Open total laryngectomy for this patient. Please raise your hands. Nobody. Great. Open partial laryngectomy, supracricoid. 1, 2, 3, 4, 5, 6, 7, 8. Endoscopic resection. Endoscopic resection wins in public poll. Okay, anyway, this patient in my hands did not have an endoscopic resection, had a supracricoid partial laryngectomy. That's a surgical specimen. And here is post-op, one arytenoid taken, one arytenoid preserved, and airway is satisfactory. That patient's done well. What I have to conclude the panel, time is moving on. What we have learned in the past hour is the following, that in the hands of the experts who have the technical ability, experience for judgment, and the volume of cases, endoscopic laser resection remains a preferable method of treatment, and as shown by the numbers, does stand the test of time in terms of tumor control. We also learned that it is not something that the man will go home and do next case tomorrow and for the second case 6 months from now. If that is the scenario in your hands, you are a hazardous endoscopic laser surgeon, you should probably not embark upon it. We also learned that there is lack of comparative data in the literature comparing endoscopic laser resections randomized to a comparable either open surgical method or a non-surgical method. So within the framework of those limitations, we should take the data as it is, respect the people who have the expertise, and those who do not have the expertise, adhere to the standards of care that you practice with. I thank the panelists for their time and Mr. Conference Chairman for the privilege of the floor.